Uh, in the previous video, I have explained about the pathophysiology, causes, clinical features, and complications, and outline investigations and treatment of hyperuricemia and gout. In this video, I will explain about the investigation step by step and management step by step. Okay, so what is the pivotal most important investigations in diagnosing gout? It is the joint aspiration, which shows the negatively birefringent needle-shaped crystal in the synovial fluid. It confirms the gout, whereas the main differential diagnosis here with the monoarthritis are pseudo-gout, which shows the positively birefringent rhomboid-shaped crystal, and septic arthritis, which will show the increased growth of the bacteria and increased amount of neutrophil in the synovial fluid. Okay, but there is a question that if the synovial fluid analysis cannot be performed, like due to the lack of facility or lack of expertise, so how will we proceed? It is the algorithm from the up-to-date 2022 with it is the diagnosis of acute gout flare. And so if you have the clinical suspicions of gout flare, at first we will do the joint aspiration and synovial fluid analysis. If it can be performed, and we will look for the negatively birefringent needle-shaped crystal. If it is positive, diagnosis of gout is confirmed. Okay, if it is negative, we have to consider the other alternative diagnosis, and if the joint aspiration shows the positively birefringent crystal or like very numerous neutrophil count with features of infection, we will treat these cause. Okay, if in case if there is no facility to perform the aspiration and synovial fluid analysis, and we will look for the features of our septic arthritis, since septic arthritis is the orthopedic emergency. And so if the septic arthritis or infection is suspected, like worms, swollen, painful joint with fever and other source of infection, if yes, we have to refer the patient to arthrocentesis and synovial fluid analysis. Diagnosis of septic arthritis is very important, and so if there is features of infection, we have to refer to the patient to the synovial fluid analysis. Okay, if there is no features of no features of septic arthritis, and synovial fluid analysis cannot be performed, we can use the clinical diagnostic rule, which include the which include the risk factor for the gout, like male sex and previous arthritis event, rapid onset and joint redness, and first metatarsalphalangeal joint involvement at 2.5 points, and hypertension and other CVD risks, CVD disease, and increased serum uric acid level. So if the total gout more than 8, it is likely gout. And so if it is less than 4, we have to look for the alternative diagnosis, and if it is in between, we will think about the intermediate possibility of the gout, and we can start the treatment trial. Okay, so although the pivotal investigation is joint aspiration, if we do not expect septic arthritis according to the clinical findings, we can proceed with the clinical diagnostic rule. Although it is not very gold standard, we can use this rule. And in this case, in this case, we will perform the joint aspiration and need a negatively birefringent needle-shaped crystal is present, or it is gout, and if it is no, if there is features of pseudo gout or septic arthritis, we can treat as these alternative diagnosis. And if gout suspicion is still high and still suspected, we can also use the clinical diagnostic rule in this case. Okay, so in this scenario, I would like to make an emphasis on the clinical diagnostic rule. And yes, okay, if the gout is confirmed either by the aspiration or either by the clinical criterion, we have to treat the patient. And so what is the option for treatment of acute gout? It is involved in the previous video, and it includes the non-pharmacological treatment and pharmacological treatment. And non-pharmacological treatment include health education about the disease, avoid the diet rich in purine, reduce alcohol intake, reduce dose of diuretics or stop the diuretics if it is not essential. And maybe it although I haven't emphasized on the ACEI, some of the ACEI could lead to the cardiac attack, and we have to avoid these. And if there is associated cardiovascular risk factor like ischemia or hyperlipidemia, we have to manage according to the risks. Okay, so it is the non-pharmacological treatment. And in pharmacological treatment of acute gout, as I said in the previous video, we can use NSAID, colchicine, steroids, or new interleukin-1 inhibitor like canakinumab, and another one is anakinra. Anakinra is also an interleukin-1 inhibitor and can be used, but these two agents are not in routine use. If the above measures fails, we can try this interleukin-1 inhibitor. So what is the first option here? NSAID, colchicine, steroids are what is the treatment of choice in acute gout? It will largely depend upon the contraindication and your fitness for the treatment. Here is the up-to-date bars for the contraindication of the NSAID, oral glucocorticoids, intra-articular glucocorticoids, and colchicine. We usually avoid the NSAID in case of CKD, hyperkalemia, and duodenal and gastric ulcer, poorly controlled hypertension, and heart failure, cirrhosis, and other risks of GI bleeding, like that. Okay, oral glucocorticoids are the short courses, not usually high risks of or risks side effects, but we better doesn't use in case of poorly controlled diabetes and history of glucocorticoid intolerance. And intra-articular glucocorticoids is usually used only if one or two joints are affected, and if it is more than or equal to 3 joints, usually use the systemic therapy. And in case of colchicine, we have to avoid it in the severe renal impairment and in case of allergy and if the patient has active diarrhea. Okay, so whatever the cause, whatever the use, the acute attack will be subtle and after initial treatment, and we have to consider the uric acid lowering therapy after the acute attack has been settled for about 2 weeks. 2 weeks after the acute treatment, we have to consider the uric acid lowering therapy. It includes the indication for uric acid lowering therapy are complications of the acute gout, which include tophi, radiological lesions like deformity, CKD, kidney stone, and if the attack became more than or equal to 2 per year, it is more than 1 attack per year. You can give the uric acid lowering therapy if acute gout flare occurs twice in a year, and if it is associated with chemotherapy-induced hyperuricemia, we have to use the uric acid lowering therapy. But it is not usually started during the acute phase. It is started after the acute phase has been settled for about 2 weeks, and we usually continue or given together with an NSAID or colchicine during the initiation of the uric acid lowering therapy to prevent the acute attack, because in case of gout in the joint cavity, the uric crystal are usually adhere to the joint. But if we give the uric acid lowering agent, it causes that the solution of the uric acid crystal, and it will dissolve into the joint cavity. If the uric acid level become rapidly low, and it will dissolve into the joint cavity, and it might cause the acute gout flare. So we usually combine with the acute gout treatment at the initiation of the uric acid lowering therapy. Okay, so how will we start the uric acid lowering therapy? The first line here is allopurinol. We start at the low dose, 100 milligram in the normal person and 50 milligram in elderly, and then titrate up to 900 milligram if needed, and about once in a month, or like 100 milligram increment in a month. We target is to achieve the serum uric acid level of less than 300 micromole per liter, and if we achieve the target, we can maintain allopurinol at current dose. If the patient is not tolerant to allopurinol, we can switch fibusulstat. It is started in the 80 milligram and increase the dose up to 120 milligram once a day. And if it is not tolerated, we can switch to the glucocorticoid agent. If the patient can tolerate the allopurinol, but the target doesn't achieve with allopurinol, we can switch to the fibusulstat because it is more potent than allopurinol. And if the target doesn't achieve with the fibusulstat, we can add or switch the glucocorticoid agent. And in whatever the use or whatever the direction, if the patient doesn't achieve our target uric acid level, the final here is the Glucocorticoids, which is the recommended uricase. It is very potent, and it is usually the last sort of the treatment, and it can be given in IV infusion every 2 weeks up to a maximum of 6 months. Okay, so it is the step-by-step management of the uric acid lowering therapy. It includes the allopurinol, fibusulstat, glucocorticoid agents, and finally the Glucocorticoids. And we have to emphasize on the non-pharmacological therapy, and if there is an acute attack, we can give anesthetic corticosteroids, and if needed, interleukin-1 inhibitor. Okay, so it is the end of the hyperuricemia and gout, and if you have any question, you can leave the question below and I will answer it. Thank you for watching my video, and see you in next video.